So let's talk about the rise of fake doctors in the UK. Well, we know in the UK for many years now, there has been a shortage of GPs in the rural and remote areas where you might get one GP serving 10,000 population, whether it's a town or a village, for instance. So as a GP serving that many population, you cannot go on holidays. And imagine if you're now retired, there's no one to replace you straight away. And as a GP, you're responsible for emergencies, doing the deliveries. You've been woken up at 2 o'clock in the morning to come and sort out a child who's short of breath. And as a patient, you can expect to wait anything from 4 weeks to 2 months if there's only one GP serving 10,000 patients. Now, any hands up, which GP wants to work in Grimsby? So basically, in 2015, the then Health Secretary of the Conservatories, Jeremy Hunt, famously declared in his pledge that he would aim to provide 5,000 GPs by the year 2020. Now, a lot of doctors were like, where are all these 5,000 GPs going to come from? I mean, Jeremy Hunt was like, we'll increase the numbers in the medical school, there'll be more spaces, and we'll change the medical school and training curriculum to make it more GP focused. Never mind those people who want to be surgeons or pediatricians, we'll make them all GPs. Does anyone remember the Golden Handshake scheme? Wasn't that around 2016, 2017, where the government and NHS was offering doctors £20,000 to relocate to rural or remote areas? I mean, bear in mind that this £20,000 was not tax-free. I mean, how far would £20,000 take you? That's about what, £5,000 a month over a 4-month period? So as you can guess, there wasn't that much uptake for £20,000. I mean, there isn't any incentive there. I mean, most doctors can work long hours doing out-of-hour services, for instance, and you can make that £20,000 within a few months. So you would not need to locate to somewhere remote just to have a £20,000 handshake, which from what I gather wasn't tax-free anyway. But guess what? In 2000, COVID happened. And prior to that, you had Brexit, where a lot of the doctors who were becoming hospital consultants, who were becoming GPs, were homesick. And when COVID happened, they went back to their families, as well as Brexit made it difficult for them now to stay in the UK. In addition to that, you've got the poor pay relative to other countries in Europe. I mean, GPs have had what? 1% pay rise in the last 7 years? That's pretty poor. Was it 3%? Then you have many doctors, once they had reached the pension age, they were retiring due to the red tape. I mean, who wants to stick around and be writing appraisals, spending 2 to 3 hours in front of a computer, writing what you've learned from a patient, something you've done for the last 20 to 40 years. So based on all these factors, the government had a light bulb idea. Why don't we have physician associates in general practice where they can see patients? We'll also have pharmacists who can diagnose and treat patients, albeit minor health conditions. Now, I remember coming across the term physician associate when I did my medical school placement back in America. This was many moons ago, by the way. I was like, who are these people? I couldn't tell them from the consultants. I mean, they both wore the same white coat. You pretty much had to look at the badge where it said in small letters, physician associate or physician assistant. So the term physician associate is not a new term. And from what I've read, they've actually been in the UK since 2003. Now, like most doctors, I do not know much about physician associates. In fact, I didn't even know anything at all about physician associates. So of course I had to do some background reading. Now, from what I know, physician associates are healthcare professionals who manage patients under the supervision of a doctor. So to get more information, I had a look at the NHS website. So looking at the NHS website, if you scroll down, it tells you what they do. Taking medical histories from patients, performing physical examinations, diagnosing illnesses, seeing patients with long-term health conditions, performing diagnostics and therapeutic procedures, analyzing test results, developing management plans, providing health promotion and disease prevention advice for patients. Most physician associates currently work in general practice, acute medicine and emergency medicine. There is a happy physician associate, you can see there. So the entry requirements, so a lot of them tend to be science graduates. So it tells you here, you need a bioscience related first degree to get into one of the training programs. Undergraduate Master of Physician Associate study programs are now available, and these courses require A-levels or equivalent for entry. Alternatively, if you're a registered healthcare professional such as a nurse, allied health professional or midwife, you can also apply to become a physician associate, right? Must have skills, okay? Don't forget academic qualifications are in everything. You need to blah, 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 that's not important. Training and development. So training would usually last 2 years. with students studying for 46 to 48 weeks each year. Holidays are needed, obviously. 1,600 hours of clinical training. That's not compared to the 10,000 hours of clinical training, a medical student would need. Pay and benefits, again, I don't know much about pay and benefits. So I'll try and look at the Faculty of Physician Associates website for more information. Again, similar to the NHS website, tells you here they were introduced in 2003, commissioned in 2004, blah, blah, blah. Scroll down, what do physician associates do? They take medical histories, again, similar to the NHS website, carry out physical examinations. They see patients with long-term chronic conditions. Seriously? Long-term chronic conditions? Can a physician associate handle COPD, diabetes, arthritis, dementia, hypertension, all at the same time? Doubt it. Perform diagnostic and therapeutic procedures. Okay, I think that's related more to hospital than general practice, unless that means taking bloods. We're talking lumbar punctures and chest drains. That has to be done under supervision, as it says. So currently, physician associates are not able to prescribe, request ionized radiation, e.g. chest X-ray or CT scans. Interesting. However, is it fair to label physician associates as fake doctors? Well, here are the issues. Now, I've met a lot of patients who have seen physician associates and they did not actually know that they were not seeing a doctor because the physician associate did not tell them, I am not a doctor. So as a surgery or reception, if you're booking a patient in and you're not telling the patient, you're not booking them with a doctor, that becomes a major problem because a patient might actually want to see a doctor and not somebody else. As we all know, there was an issue of a 30-year-old woman, who had a blood clot, which was misdiagnosed as a sprain, long COVID, and eventually anxiety, and unfortunately she passed away. However, regardless, there's plans to have 10,000 personal physician associates by 2037, as well as to be regulated by the General Medical Council, which is the GMC that's responsible for regulating doctors. As you understand, there's been a huge uproar about this because that's going to be bloodlines, a lot of confusion between who are doctors and who are physician associates. Now, from what I've gathered, a PA or physician associate is paid 11,000 more than a newly qualified doctor who needs less supervision and has more autonomy than a PA. So basically, you as a newly qualified doctor, you're paid 11k less than a person who you might end up supervising. Now, I believe there is a role for PAs in general practice, but I also think that this needs to be clear-cut and definitive, as patients need to know who they're seeing and who they want to see. Do they want to see a PA who has less limited knowledge and experience than a doctor, for example? And no, a PA should not be making medical diagnosis as they've not been through 5 or 6 years of intensive medical school training. They've not been trolling up and down the hospital wards 2 a.m. in the morning to fit a chest drain, or see a chronic obstructive pulmonary disease patient who's been very short of breath, or someone who's recently had a stroke and looks like they're not about to make it in the next 2 minutes. In short, they lack a depth of experience. 2 years of training is not sufficient for you to do the role of a doctor. Now, why is this an issue? This is an issue because, as you know, like I said earlier, there's been a shortage of GPs. So there's been this new scheme called the ARRS, and a lot of GPs surgeries, or a lot of GP surgeries, are now hiring PAs in place of doctors. So GP locums are now complaining that there's no work, and the work that they used to do have now been given over to the PAs. I mean, it would be nice if the PA introduces themselves to the patient and says, hello, my name is Vicky, I am not a doctor, I am a PA. And I feel that the word physician in itself is misleading because physician obviously is synonymous with the word doctor. Then you also have the pharmacists who now have more of a major role in dealing with patients. You've got pharmacists who can now diagnose and treat patients. Now, I do not mind the pharmacists helping us out with the UTIs, the sore throats, the conjunctivitis, all that junk that we normally see in general practice that we really need to weed out so that we can deal with the more complex cases. However, what we have seen is some of the pharmacists actually dealing with these complex cases and now telling patients, this is what you need to go and get from the doctors. So we now have patients coming to us and say, I've seen the doctor, I've seen the pharmacist, and the pharmacists have requested that you should order me an MRI scan of my brain because I might have a brain tumor because I've had this headache going on for a while. I'm like, hello, I need to do an assessment. Has the pharmacist done a neurological examination? No. Hello? And to model the issue even more, we also have advanced nursing practitioners. Now, these have the ability to prescribe, diagnose, and order investigations. Now, I feel that advanced nursing practitioners are actually more qualified than your PAs, but the problem is they have the word nursing. So when you see an ANP or an advanced nursing practitioner, you know you're seeing a nurse. But when you're seeing a physician associate, it's a bit confusing. Am I seeing a doctor or am I seeing somebody else? Also, I cannot tell you with confidence that I can distinguish between an ANP and a PA as the lines are getting blurred. As we know, nurses can also become physician associates. So it's very important that the patient here needs to be considered and be able to have that informed choice. Am I seeing a pharmacist? Am I seeing an ANP, which is an advanced nursing practitioner? Am I seeing a PA, which is a physician associate? Or am I going to be seeing a doctor, such as a qualified GP? And this is the reason why we now have the term fake doctors, because it seems like the ANPs, the PAs, and the pharmacists are now playing the role of doctors due to the lack of shortage of doctors in general practice. So I hope this is clear, I hope you've understood, and please feel free to subscribe.